For decades, we've been told that weight is simply a matter of calories in versus calories out. But what if that's only part of the story? Today, we're joined by one of the nation's leading pediatric bariatric surgeons who has spent over 20 years treating childhood obesity and studying the science behind it, from the cellular level to patient care. He is on a mission to transform how we understand and treat obesity, challenging long-held assumptions and bringing a new evidence-based perspective to the conversation. Dr. Evan Nadler. Doctor, welcome to the show.
Thanks, Hurricane, for having me, or Hurricane H, or
Hurricane is
however we
fine.
best use
Hurricane is fine.
Hurricane for short. Hurricane H
Yeah.
seems too long, but yeah, thanks for having me. I think I mean the shame and blame that these poor families, these poor children have suffered for all these years is sort of the reason behind my passion and advocacy work. And I think the while I am a surgeon, I have a sort of 360 perspective on this disease that it's not like I think everybody should get surgery. It's just I just think it gives me a different sort of understanding because I used to see the worst, still see the worst of the worst cases, so I know how bad it can get.
Well, doctor, I mean, this is a big topic, and in the U.S., obesity is just a big deal. I mean, and it's, I
Worldwide,
think, well,
worldwide.
worldwide, yeah. I mean, that is true. That is, I mean, it's becoming more, I travel a lot, so I see less of it, but you're right, it is a trend because the food, the culture has changed, the way we eat, the way we even our life, styles have changed. I mean, sedentary, sitting a lot, there's a lot of gaming, TV, couch potatoes kind of concept, but it's happening more and more. And I think if you look at I look at some old videos and things like that at the beaches and stuff, people were different. I mean, they looked different. They were in shape. I mean, even
Fewer
if they
ta
were not,
fewer tattoos. You probably noticed too, because when I go to the beach,
that's,
first thing that I'm like, oh my gosh, when did tattoos become like everybody had to have one? Like, when did that happen? I missed that
uh,
memo.
li- listen, I don't have one. I was never a big fan of those things. And, but listen, to each his own, as they say, right? People
Exactly.
do what they have to do.
Don't judge.
But But you know what? Okay, so the tattoo maybe is something that is cosmetic that you want to add to, but obesity is something that actually going to hurt you physically, and
100%.
and it's sad that first of all, I think the problem is global, as you said, but in adulthood is one thing, but when we start talking about younger children, more and more and more, and doctor, I would leave this to you to give us a little bit more of a history of how this is all going into where we are today. Like, I mean, you probably have seen it in the trends and the statistics. So if you care sharing some of that with us and the audiences, because I think people have to be aware, especially parents, and even the kids themselves. Because I talk to my kids about food, about nutrition, about this and that, and I always get a challenge. I think it's time for people to start hearing it, from someone who's an expert at this. Like, listen, this is the formula. This is the myth. This is what happens. This is what you should be doing, not be doing. So, doctor,
Right.
let's talk about that, like the whole story behind it, and also,
Yeah.
if you don't mind, pediatric bariatric surgery. Like, let's
Yeah.
also explain that to our audiences.
Sure. Um, so the yeah, so one of the reasons I'm doing podcasts and I'm now on TikTok and Instagram is to reach the kids themselves, obviously, because they're not their lives are dominated by social media these days. So I do think they need to hear the message too, for sure. And in terms of the global problem, it really depends on where you travel. There, for instance, the Middle East, the Gulf, their obesity problem is just as bad as ours here in the US. It's just not discussed nearly as much. But the scenario really is that, I mean, everything's important. Better food quality, cheaper food that is of quality, better access to cheaper and healthier food, more access to play spaces, more access to, you know, gym class and working out and all those things. But those things alone are not what's driving the obesity epidemic or the childhood obesity epidemic. It's far more complicated than that. And they're related because there's this field of study that's called epigenetics, which is sort of how the environment impacts your genes and how your genes turn into proteins and expressed in your body, which is too technical for most people to care about, but basically it means how your genes work. And the all the stressors in the environment, like air pollution or forever chemicals or ultra processed foods, and even things like lack of sleep or childhood trauma events, all those things can change how your genes work. And then that can actually get passed down from individual to child. So over the last, let's say 50 years now, 40, let's say 40 years, um, it's been a combination of the genetics of people getting passed down from generation to generation, but also this epigenetics or the epigenetically modified genes that get passed down. And for most people out there, maybe that's way too complicated or too much TMI or not necessary information. But what I think everybody will be able to see is that obesity runs in families, right? Like, when you see a child with their parents, generally the child and the parents sort of look the same in terms of body shape. Now that's, again, oversimplifying it, but the reality is that just focusing on diet and exercise it doesn't work, and we've sort of shown that over time doesn't work for most individuals, and it certainly doesn't work for the population. And that's why you can actually now get the GLP-1, or at least one GLP-1 medication is approved for children. And as you mentioned, I've been doing bariatric surgery for children for 20, no, 15 years, 16 years now. And actually more than that, 20 years now. And I started doing that mostly because these children were desperate and there weren't any medications back then. And I sort of knew that if you have type 2 diabetes as a 13-year-old, it didn't make medical sense to have you wait until you were 18 to get care for that. And so along the way, I've gotten a lot of criticism. And, especially in the early days. And back then, and even now, I have always said, well, I'm either going to be a genius or a heretic, and I'm not sure which, but I'm not going to sit by and just let this go untreated. Like, I have to do something. And I'd like to think that the most of the evidence is trending towards just ahead of the game. I'm not going to use the genius word because that's certainly not who I am, but I was just ahead of the curve in terms of understanding the disease, its implications, how difficult it is to treat. And frankly, now I'm actually writing a book about all that, about my last 20 years, what I've learned for, parents and children. And that should come out hopefully next year around this time. And, I just want to keep the conversation going. We're
Well, doctor,
starting.
so yeah, it's a great start, and there's plenty there. I mean, we can break this down. It would take us a whole day,
For sure.
But there's a
At
there's a
least.
couple things. One thing, doc, is you started this 20 years ago. That is a couple of decades already, and to your point, it is cutting edge. Something that you've done. Probably people like why you get into the kids early and doing surgeries and stuff like that, and people may not understand sometimes that it's preventative. Now, certainly surgery is a last resort when you have to, but certainly if there is no other option, to your point, and now you're getting in a worst case scenario diabetes at early onset, especially at a younger age. And listen, my mom was diabetic for 30 years, but she had it at a later age. But certainly when you have what do you call it, a child in a concept of diabetes, and they have to have the insulin and all the stuff, I mean, certainly the body's going to get destroyed, before you know it. And so certainly an easier intervention would be to actually do something about it to prevent all that. But I do want to go to a couple of things. Now, doctor, your basic, practice was pediatric as a whole. I'm assuming before surgery. So
Mhm.
you've
Well,
worked with.
in pediatric surgeons actually train as adult surgeons first and then do specialize in children. So while I know obviously pediatric diseases in general, I'm not a trained pediatrician. I'm a pediatric surgeon. So it's a slight difference. But yes, I do know about childhood development and all that kind of stuff.
No, perfect. I just because I mean, surgeon, but the idea is that, kids.
Yeah, yeah,
Listen, I
for
have
sure.
I have children, so I want the best for my kids, and I know
Of course,
everybody. There's no one out there that's not going to want to, see their kids in the best shape, and health. I mean, because at the end of the day, it's really health that matters, right?
100%.
Because all this contributes to either a better living, better health, vitality, or really just a very bad, lifestyle, a bad, I mean, living with the disease, and I think you mentioned the word disease. It's a tough place to be for the person. Because I listen. I mean, again, I'll give the example of my mom. Just seeing, and my best friend is also diabetic. I mean, I see the intensity that it takes, and just little, if you eat wrong, you do this, you do that, and it affects you. If you don't eat on time, it affects you. Just maintaining it. I mean, now with the monitors and everything, at least you can control a little better, and you have all these pumps and things. But even with all that, it's still difficult, and your body is just not. And I love what you said that this is also a worldwide pandemic, or it's not just isolated in the U.S. Uh, and yes, of course, there is something beyond which you mentioned genetics, because I think that's the whole thing. The idea, as I started the show, is to we're talking about weight gain versus obesity. I think there's a distinction, because
Hmm.
you can gain weight and not be obese and be able to monitor that. Your metabolism may be whatever. You're just not doing things, but certainly you get to a point where you have to do what you have to do to change things, and that's when things go haywire. And obesity is something that builds up quick. I love what you said about the idea that you can see a trend in a family. Now, of course, some people can say, well, you guys are judging and things like that. And I just want to, clearly state
Yeah.
this. This is for you folks, out there to just understand this. And I love what you said, Doc, about being on social media, to sharing this value and even writing a book about it, because we have to face the music and face the reality
Yeah.
of things.
And I would argue it's actually the opposite of judgment. Like my office was always is always completely non-judgmental. And I'm not saying that it runs in families, so it's like families' fault or blaming them. It's just, it's just one of the medical sort of facts that it gets passed on. There's something called the intergenerational transmission of obesity, which is how it gets passed on from parent to child, and that's a thing. And I think the my goal is to actually remove all the stigma and bias around the disease, so that people can get help, and whatever that help might be. It may be just lifestyle changes, it may be medications, it may be surgery, it can be whatever a family chooses at that time. But I've gotten, I mean, I've gotten all kinds of criticisms over the years, and it always comes down to the same thing. Like, this isn't surgery that people are getting for cosmetic reasons. This is surgery that they're getting for their health. Or if they're on a medication, it's the same thing. It's not because they want to, look better for their prom or quinceañera or something like that. It's something that they need for their health to be optimized. And sometimes that's mental health. It doesn't always have to be physical health. There are a lot of connections between the mental and the physical health, especially with obesity and childhood obesity. So, the point is really just it is a disease, not a lifestyle choice. Nobody chooses to have obesity. Nobody chooses to have their children have obesity. It's not due to bad parenting. Um, it's just a complicated chronic disease that requires sort of a 360 approach if we really want to make a difference.
Well, doctor, someone can argue, it's not a lifestyle, but people actually have changed their lifestyles these days. And, there's more. I mean, when we were kids, at least I remember this, as a kid, I didn't sit home, and we were out there every day. I mean, we were running all over the place. I mean, I was super skinny because I was literally not eating much, just playing and doing stuff, right? I was very super hyper. Now, of course, I think there is a change in how we behave, our behavior has been. I mean, with technology
Yeah,
and I mean, even the gaming industry has impacted, I think, this. Not to
sure.
blame, the gamers, but I mean, there are even lawsuits out there about this stuff, So there is a level of that. So someone can say, well, maybe if we don't have these types of behaviors, we would have not, not get to the weight, gain concept. But when you're talking about the obesity as as a disease itself. You're talking about a different level that may have some contribution of all the above, but really it's really your body, your metabolism is not,
Right. So,
operating not optimal.
right. So what we know from clinical trials, and there are hundreds of them, is that the most intense like diet and exercise programs for children with obesity result in about a 5% total body weight loss. So that means if you're a 300-pound teenager and these intensive programs actually require 26 contact hours. So that's basically either a half hour every week or 1 hour every other week. And to get the 5% weight loss. And that 5% weight loss, if you weigh 300 pounds, is 15 pounds. So after putting in 26 hours of work, you now weigh 285. So you can imagine that that's not really cost effective in terms of if the cost is like the time and effort you put into it. So I don't disagree that we need to change all those things if we can, because some of them are sort of unchangeable. Like we're not going to roll back technology. We're not going to roll back the gaming industry or there was a time where I remember where people were pitching the Wii Fit, the Wii
Yeah, I know.
had a fitness episode, whatever game that you could play to help that we used to tell kids, if you don't want to leave the house, here's something you can do to try to increase your exercise. But again, we just know it doesn't work for people once they get to having obesity. Yes, for like standard weight gain, it certainly can help. Obviously, anyone who's tried to lose weight, no matter what size they are, when they do that, will notice that their body plateaus. And so there's something called metabolic adaptation, where your body actually wants to maintain whatever weight you're at. People might remember that movie, Super Size Me, where the guy ate McDonald's like every day or 3 times a day for like a month or something and gained a truckload of pounds. And then when he stopped and went back to his normal diet, the weight came off because his body didn't really want to be however much that weighed. So that's why I say it's super complicated. It's not just like, as you mentioned in the intro, it isn't calories in, calories out because your body's metabolism changes. So even if the calories in, calories out stays the same or becomes negative, like you burn more calories than you take in, your body is going to fight that because your body is designed not to let you starve to death or wither away to nothingness. So, it's not, it's programmed. Your brain is programmed to keep you alive at all costs. So if it senses you're losing too much weight in its mind, and that's a whole nother topic of how the brain decides what weight you should be. But if it feels like you're losing more weight than you should, it'll stop you. It won't let you lose more weight. It's why people can go on these 90-day hunger strikes and not, a 90-day hunger strike, in theory, if you think about it, that should be, if you don't eat for 90 days, it's hard to imagine how you stay alive, but your body figures it out. So anyway, that's why, again, I keep going back to the fact that it is a disease and it's a complicated disease. And I think childhood obesity may even be either a more severe type of the disease or even a completely sort of separate form of the disease. Because again, if you think about, like I've seen 10-year-olds with no reason to have type 2 diabetes other than their obesity and no reason to have their obesity from like a genetic standpoint or any other standpoint. And if you think about a 10-year-old, I mean, how bad would they have to eat and how little exercise would they have to do to get to diabetes? I mean, it doesn't actually make sense, right? It's like they've only been on the earth 10 years. How could they possibly get there just from the external environment and an external environment that they probably didn't even have control over for the first 5 to 6 years of their lives, right? So again, no parent is feeding their child into diabetes at age 10. It's just not, it just doesn't happen. And unfortunately, the cruelty of our world or reality of our world is that people will still blame them, right? Like I'm sure there'll be comments on this podcast saying, that's not true. I see the kids and they're eating like crap and blah, blah, blah. And again, it's actually really complex. There's the socioeconomic pressures. There may even be, brain, especially in adults, they talk about food addiction and how the brain can sort of force you to eat stuff that you know is bad for you. And that's in part how the GLP-1 medications work, is they get rid of the food noise. So again, I think we're just really starting to understand the disease because of these new medications. And hopefully there will come a time where the stigma around it, like no one would blame you as an adult if you were taking your blood pressure medicine. They would never say, Hurricane, man, if you just ate better and exercised more, you wouldn't need your statin or your blood pressure medicine. But those diseases are just as equally related to diet and exercise as obesity is. But everybody talks about obesity like, oh, if you just ate better and exercised more, you wouldn't have it. And my personal guess is because you can see everybody with obesity, or at least you think you can. Whereas I can't look at someone and say that I know that they have high blood pressure. So somehow that changes how we perceive these diseases, which doesn't necessarily make sense, but I think that's just the reality of the day. Like, every adult, almost every adult over the age of 50 is on a statin, and no one blames them for their, lack of being able to control their cholesterol with diet and exercise. But if you put on weight, people start to blame you.
Doctor, you're making a great point about the idea that, because it's visual, right? So people are looking, so they can easily, contribute that and say, oh, this is the cause. But, like, by the way, I've seen people that are like super, they look so fit. And then when they do their workout, they work up in terms of blood stuff, they actually come up with high cholesterol, LDLs and all this stuff. And it's like, how is it even like I have cholesterol and I don't look like someone who typically should be looking like that? I mean, as the stereotype
100%.
will go. And so that is very common, and I've heard stories. We've had discussions about it. I see that on the social media. There's a lot of discussions about it. But doctor, so let's break it down scientifically. Like, how does this whole disease operate within the body? Because it is genetics. Because when we talk genetics, and you mentioned metabolism, so metabolism, you have hormones, you have all stuff. So we are regulated somehow. Is this all connected? I mean, also you talked about the people who are fast, right? And there's a whole thing or philosophy about if you fast, your stem cells, your body kind of starts kicking in and goes on
Yeah.
hyperdrive and all that. So let's kind of connect the science together to all these,
Okay.
because these are things that we hear all the time,
Sure.
and most of us don't understand them from a clinical
Sure.
aspect of it.
Yeah. Well, let me start by saying, like, the whole intermittent fasting fad is intermittent fasting really works just by calorie restriction. There's no magic to intermittent fasting, although a lot of gurus will tell you that there is. But almost all the data says that there isn't. But it is a way for people to control their calories. So if that works for you, have at it. Just don't necessarily believe that it's somehow changing your metabolism or hormonal status, because it's not. Those studies have been done and it doesn't really do that. But to get to your question directly, and it's super complicated. But your hypothalamus, which is the sort of hunger and fullness center in your brain, has a set point where it tells you sort of what your weight should be. And that set point is really, in large part, determined when you're developing as a fetus inside your mom. And then it can be impacted by, as we talked about before, some of the things like lack of sleep or childhood stress, or we think some of the pollutants and forever chemicals, and maybe even ultra processed foods. So that can raise your weight set point above what it might have been determined to be when you were developing. And I should say that when you're developing fetus inside your mom, if your mom gets diabetes, or if your mom puts on too much weight, or if your mom has exposure to some of these things, that can also change your hypothalamic set point and make it so that you're at higher risk for obesity as a child or an adult. So that's sort of the beginnings of it all. And then at a sort of cellular level, let's say, the way that obesity or weight gain makes you sick is that you have a certain number of fat cells in your body, and they are designed to store the energy, the extra energy that you take in. And that's a normal process because we were all, programmed so that if we went for long periods of time trying to, hunt the lion or, there was no food for a long time, we needed to have stores to keep us going. Obviously, in this day and age, that doesn't really happen. And then, so when your fat cells get oversaturated, like they're small, and then they get bigger as they store more fat, and at that point, they get basically overstuffed. Then they start leaking mediators, hormones type things into your bloodstream. And that's how it causes problems for, let's say, your muscle in terms of insulin sensitivity, or your liver in terms of metabolic dysfunction associated steatohepatitis, long, big word. And everybody's storage capacity is also different, right? Like, so I've seen kids with a BMI, body mass index. People may or may not know what that is, but it's a ratio of your weight to your height. And it's how we sort of screen for obesity. I've seen kids with, BMI in the obesity range, but not super high, let's say BMI of 40, and they'll have sleep apnea or diabetes or some other medical problem. And then I've seen kids with BMIs in the 80s, weighing 500 pounds, who are walking around pretty much unaffected by their disease. So it's not linear by any stretch of the imagination. And it's actually those cases that have always been the most fascinating to me, because I don't, like, why can you exist like that? Why can you be 16, weigh 500 pounds, and basically be living a metabolically normal-ish life? Like, I'm sure digging deep enough, we could find some abnormalities, but, not having diabetes. Yet here's another kid who's BMI is 40 and they do. So that, like, when you see that kind of stuff, you start to understand that, again, it's not a simple problem, but a problem that affects different people differently, which, by the way, you should never ask anybody to, should never tell someone, if you just do what I did, you'll lose weight. Like, let's say you were struggling with your weight and you did something and it worked for you. And you think you're being helpful by telling your friend or colleague or kid or whatever, just do this because it'll work for you, it worked for me. That's totally untrue. There's no pairing. There's no correlation between what worked for you and what will work for somebody else. It's totally individualized, based again on sort of genetics, epigenetics, and all this other stuff. So the point is, it's been a fascinating ride for the last 20 years, because it's just, I've seen so many unexpected things that really have opened my eyes to this disease. And again, it's why it's become my passion, and why I really want to try to help people get over the stigma of it and try to understand it more on a like a scientific level, because it's just not, it's not as easy as diet and exercise or calories in and calories out. It's just not.
Well, doctor, thank you. And I think what people have to, at least what I'm getting, and I might correct me if I'm wrong, you know, we are talking about a special disease here. We're not talking about gain of weight that can be due to lifestyle. This is something that is completely uncontrollable, and it's beyond, the person. Like, no matter what you do, the body is just regulated differently than what we would say a
So,
normal, level. Am I getting that right?
yeah, so I actually like to, so I make a joke, or not, maybe not a joke, but I make
Go for it.
it's not really a joke because it's not really funny. It's more of a, I don't know. Anyway, we've learned a lot about autism over the last, 20, 30 years. And now we call it autism spectrum disorder, because we know that some people may have like very few signs or symptoms, and then others may have a lot. So we've changed the name. We don't call everybody autism. We don't say everything, autism. We don't even use things like Asperger's or those other diseases anymore. We just call it autism spectrum disorder, because we realize it's a wide range of how it affects a person. So I sometimes tongue in cheek say we really should be calling obesity weight gain spectrum disorder because it affects different people really differently. And, um, it may not affect you at all in terms of your metabolic health until you get to a certain point, or it may affect you and you don't know it because it's what you're used to and you don't really realize what you would feel like if you didn't have that extra weight on. Or it can make you super sick. I mean, I know kids who lost I know kids, I've taken care of children who have lost their vision due to their weight. There's a disease called, well, it's now called idiopathic intracranial hypertension, but it used to be called pseudotumor cerebri. And it's a disease that would, at relatively low BMIs, would impact people's vision. And I would do surgery for that, and their vision loss would stop, and their vision would sometimes come back. And to like again, huge I'm helping people keep their sight by doing weight loss or weight maintenance or obesity surgery on them or weight loss surgery on them or whatever you want to call it. Like again, like those sorts of experiences just have really changed the way I think about the disease. And I think again, in the book, which I'm like in the process of writing right now, those are the stories I have to include to get people to sort of, I think, understand what I'm talking about. It's just, I don't want to, I mean, I can't, it'll be too long a book if I tell every story that's come my way. So I have to figure out what actually people want to hear and what they or need to hear, want to hear, need to hear, and what I can leave out. But that's why it's not going to come out until next year.
Well, doctor, I mean, what you're talking about is 2 decades of quite a bit of experience in a lot of different cases, different age group, and I thank you for bringing that to our audience as the analogy with autism, because yes, there's some autism level that you can barely even notice, very high functional and so on and so forth. And to your point, this is more of a nice little, what do you call it, like just a platform with a lot of different pieces to it, and therefore someone can be on the lower end versus the higher end. But you did mention something earlier about it starts in the womb, as the fetus is in the belly, but some of the behaviors of the parents or the mom specifically can contribute to those genetic transfers, and being, for example, you said sleep, or maybe food, stuff, could be a lot of things, but like some of them you mentioned, specifically sleep, we see a lot of that today. I mean, people don't sleep much, so there is a way, to a degree, and again, this is what we have you to share this with us. uh, it sounds like if the parents kind of take care of themselves a little bit, and maybe are more on the preventative side, especially if they know that they expecting a child, to do things. I mean, we know that about alcohol, yeah, or smoking. Like, yeah, we don't smoke, we don't drink,
Right,
but then there's all the other stuff that we continue doing, that but we don't put a connection to the
right.
risk factor. I mean, we hear about diabetes being transferred from
Yep.
parents to kids. I mean, there's always a
Hmm.
risk. So let's talk about, like,
Yeah.
those things can be
So,
preventable.
right. So again, I don't want to blame any pregnant mom because that's not what we're here to do, right? It's not.
Course not.
So I don't want to say it's necessarily their behavior. What I do think is that, and it's not just the moms, it's the dad too. And there's a lot of um, dad related health risk. Um, that's not obviously the in utero environment, but there's a lot of dad related health risk. And so, yeah, so people ask me, let's say, what would you do if you really wanted to change the obesity rates in America? Like, how would you achieve that? And what I would start with is what you were sort of saying, which is if young adults paid more attention to their health before they have kids, and as we all know, because we were all, well, those of us who were young adults at one point, we all know that we never saw a doctor and we never cared at all about our health because we were invincible or whatever. We just didn't, we were out partying, whatever we were doing. We weren't going to the doctors, I'll tell you that. Um, so that segment of the population is actually probably the most important segment of the population to try to help educate because yeah, if they try to maximize their health before they have a kid, not only will that sort of maximize their epigenetic risk, They can't do anything about their genes. Their genes are their genes, right? You inherit what you inherit. But they can impact their epigenetic risk, and they can definitely impact the in utero risk. And we know that, if moms get gestational diabetes, not only do they increase the risk of their child having diabetes and obesity, they actually increase their risk of having a neurodevelopmental disorder like autism. So that's like a sort of another one of those, like, who thought that that would be the case? But that's actually been um, that was published relatively recently, like 6 months ago or something. Um, so there are modifiable factors for sure. And then on the flip side, if you think about when that kid is born, if that family is already sort of in tune with healthy behaviors, then that child is born into a household that has healthy behaviors, which is probably better than being born into a household with unhealthy behaviors. Again, it's not, I can't prove that necessarily, but you do know that, or we do know that children's eating behaviors are sort of solidified somewhere between ages 6 and 12. So if you're in a healthy eating household, you are likely to have a healthy eating life ahead of you as a child. So there are lots of benefits to trying to get young adults, young folks to pay attention to their health and optimize it before having children. So that would be my one sort of pitch to them.
That's big, Doc. I mean, obviously, to your point, when you're younger, you're having fun and stuff. But certainly, if you do plan to have a family, it's a responsibility, right? And so well, it's not a blame, and I appreciate what you said, and we're not blaming anyone. But at the end of the day, sometimes we're just not aware that we might have that impact, and I think so. We
Right.
just kind of like, I'm just having my life, but your life has a direct impact on the next life that you're actually bringing
Exactly.
about to this world. So it changes the dynamic. And again, we are conscious about certain things, like I said, cigarettes and alcohol has been more prevalent in terms of like
Yeah.
you can't do this when you're like pregnant. But and by the way, I love what you also stated because you're right. We always kind of relate the delivery and the pregnancy to the mother, but we forget that the father has a contribution too. I mean, there's
Yeah.
there's there's two components that make the baby, right? So there's a male and a
100%. Yep.
female component. So there is genetics that come from both sides, and therefore there is that behavior that can be in the genetics and or the
Yeah. And
deficiency
there's
that can
again,
be.
and some of the epigenetic stuff is thought to, through the sperm, and that your sperm, the genes in your sperm are different because you were, again, having ultra processed foods or forever chemicals or whatever the negative actor is. But there are lots of data that show that the men are significantly involved in that baby's risk.
Well, thank you, Doug. So now there's one thing that I've heard before, and again, and you probably can bust this myth today, uh, or or if it's a reality. Are they communities that are prone to obesity more than others? Because we hear this all the time. There are some communities that just have a lot more of rampant obesity, trends than others. Is that a thing? I mean, you're shaking your head. You're
Yeah.
not. I mean,
So,
it's a
well,
it's
because
a real
it's
thing.
right. So if you look at in kids, the two highest risk groups are Hispanic males and African American females. And there is certainly also a socioeconomic component to that. There's also obviously an ethnic component to that. Um, and it's interesting because, well, it's interesting to me, maybe others, but there are diseases, for instance, the liver disease. Liver disease is more common in people of Hispanic descent and less common in African Americans. African Americans are more likely to get diabetes from their weight than they are liver disease from their weight. And then if you go to some communities like Southeast Asia, let's say, or Southeast Asians living in the US, but let's say in India. Um, in India, the BMI criteria for weight loss surgery, let's say, are much lower because people of Southeast Asian descent really can't handle excess weight very well. Their body starts to function poorly at a much lower BMI. So like in the US, let's say cutoff for surgery is a BMI of 35. In India, it's a BMI of 28 because in India, they're already getting diabetes at 28. Now, that should also be basically come back to the US in terms of different ethnic groups have a different response to excess weight. And so having this sort of uniform criteria, I mean, it's the same old story in the US forever. It's like everything's based on white males. So like all of our recommendations are basically generic white male derived when they really should be more tailored to ethnicity, gender, socioeconomic status, all these other things. But that's just not how we do it, and maybe not how we'll ever do it. But personalized medicine would be far more effective than the sort of standardized criteria.
Thank you, Doc. So I know kind of you talked about obesity in general, like for kids specifically, but you mentioned something about adults, and you see a little bit of similarities. Are they really the same? It's a different, or are they completely different concept? Because I think we need to clarify that for our
Yeah,
audiences.
I mean, I think so. There's certain diseases in children, certain consequences from obesity in children that you don't see in adults. For instance, there are orthopedic issues that children with excess weight suffer from because their growth plates are open, whereas adults, they're not. So those diseases don't even exist in the adult world. And we also know that children with insulin resistance or prediabetes and obesity progress to frank diabetes faster than adults with prediabetes or insulin resistance. And so I think the adult world, you probably have some people who are food addicts, some people who are struggling with their weight from a mental health standpoint, side effects from other medications, a whole host of, again, socioeconomic pressures, a whole host of reasons why adults end up developing obesity. In the pediatric population, I view it as somewhat purer, more pure, because a lot of those factors, again, haven't really been around long enough to have a huge effect. So in my mind, childhood obesity is a much more genetic and epigenetically driven disease. And for that reason, it needs to be actually tackled more aggressively as opposed to less, which is that old myth that it's just baby fat and they'll grow out of it. The data actually are that, this is somewhat shocking, but 85% of toddlers with obesity go on to be adults with obesity. So 85%, and that's of 3-year-olds. And if you're a teenager with obesity, now you're in the high 90%. If you're a teenager with obesity, the chances of you going on to adulthood without obesity are really small. So again, that's why it sort of needs to be tackled early, or at least addressed early. And I'm not saying that 4-year-olds or 5-year-olds should necessarily be getting on medications or getting surgery, but they should have something. They should start the conversations about healthier eating and exercising more and all those things, because the baby fat, they won't grow out of it. And I like to talk about obesity similar to how we used to talk about cigarette smoking, which you brought up earlier. So with cigarettes, we always talked about pack years. So it wasn't just that you smoked a pack a day, it was how many years did you smoke a pack a day? And if you smoked a pack a day for 10 years, your medical history said that, Hurricane was a 10 pack year smoker. And we all knew that that meant a pack a day for 10 years. And we described it that way because your lung cancer risk basically was related to not just how much you smoked at the current time, but how long you've been smoking that much. And the same thing is true of obesity. It's not necessarily what your BMI is or your weight is or your metabolic health is today. It's how long has your body been fighting against it. If your body's been fighting against it for 10 years, that's much worse than if you just sort of crossed the threshold into obesity last year. So we don't have a clever term like pack years to use, but I like to think about it that way because the damage is cumulative. It doesn't like the dysfunction in the body, the cellular damage, the all that stuff, even the mental health damage. It doesn't it doesn't stay stagnant. It gets worse the longer you have the disease. So again, like when I'm out there trying to convince people to take the disease seriously, I have to point that out. I'm like, why would you wait? Why, if an 8-year-old struggling with weight issues, why aren't you addressing this in your primary care office or at your pediatrician's office? Like, why is it just being sort of, well, we'll check your weight again next year. You should really eat better and try to get some more exercise. Like that's not adequate. That's not enough.
Well, Dr. Tinker, you're touching on a few things. One is, so you're right. I mean, kids go to pediatric doctors, just to do the checkups and stuff. I mean, is there especially if there is a noticeable, I guess, appearance, right, of obesity, would there be a recommendation to potentially get a special test that would actually identify the epigenetics and things at that age to determine whether this is a true, this is just a little kids fat, or is it this
Yeah,
is disease that is going to get worse in the next couple of years? I mean, is that something
sure.
that is
So
to work
so
with?
you can't really test for epigenetics right now. That's not their lab. There's not a real
Okay.
cost-effective lab test that can do that. But there are things, like in adults, and more kids are getting this checked too. But hemoglobin A1C, like prediabetes, is now a real thing. And actually, the simplest thing to do, frankly, which people, even pediatricians, don't really necessarily check for this, although they do more so now. But when I was first starting out, a lot of, and actually, this is another story I need to tell in the book. But a lot of kids would come to see me, and they would have something called acanthosis nigricans, which are dark circles that go around your neck. More prominently, easier to see in African Americans or people of color, sometimes with skin tags, thickening. You've probably seen people with like the skin folds, and you can catch that really early, actually. And it's the first sign of weight-related metabolic dysfunction. And I'd be having a clinic visit with a kid and their mom or dad. And I would say, I would pull down their collar and I would say, you see that darkening skin around, a darkening color around their neck, that's a sign that their body is not handling their excess weight well. And the kid who would look over at their parent and say, see, I told you it wasn't dirt on my neck. And because the parents have been trying to scrub it off for like whatever, a year or however long. And no one ever told them that it's actually metabolic dysfunction that causes your melanocytes, your skin cells, to get discolored and cause those changes. And so that's a test that people can do without anything special. Like I can do that at home. Just look at your kid's neck. And there are other places, elbows, bridge of the nose, there are a bunch of cheeks, knees. There are a bunch of places that can be seen. Now, for families who are struggling with severe obesity, let's say, there is some free genetic testing that people can get done that is not necessarily clinical grade, but it's a great sort of screening test. And there's a website called Uncovering Rare Obesity that I think you still need your doc to request it for you, but they send like a kit to your home and you swab the inside of the mouth and then you send it back to the people and they give you a breakdown of your genes and it looks at about 100 different genes that are potentially related to obesity. And I used to use that a lot to help understand what you were just talking about, like if there were a lot of genes or even a couple important genes that had variants, what we call variants, then I would say to the family, I said, listen, this is probably something that is going to be a lifelong issue and unresponsive to sort of the less intense interventions, and that you might need to move more quickly toward medication or surgery or whatever. For sure, go ahead, start doing the lifestyle stuff because everybody should be doing that, including you and me. But don't spend 6 months doing that because if it doesn't work, it's not likely to work. And if it doesn't work, you don't want to wait 6 months. You want to start the next thing in a couple months or 3 months or something. So So yeah, so that's something people can do, and they can tell their pediatricians or primary care providers about it. And unfortunately, in this pediatric obesity world, there's just a ton of self-advocating that folks need to do because, pediatricians didn't learn about obesity in their residency programs, and medical school curricula don't have enough on obesity or anything on childhood obesity. And so there's a lag between what people know, based on when they were in training, if they didn't do some extra training afterwards to learn more about it. So yeah, unfortunately, I still get emails and questions from families. They listen to my podcast, they have a question, they email me because they can't get any help in their own, community. And I always try to point them in whatever direction I can to help. But it's tough. I mean, there aren't enough pediatric obesity specialists out there, especially to cover the 15 million children that suffer from obesity. And there are relatively few pediatricians or primary care docs who are willing to treat it, just in their office like they do with asthma or ADD in the beginning. So that's another sort of advocacy effort for me is I'm trying to get the education platforms out there so that docs, NPs, physician's assistants, whomever is taking care of the children in the primary care offices get more comfortable and start doing more to treat obesity than just telling folks you need to exercise more and eat better because that's not enough for most of these kids.
Thank you, Doc. And you touch on a couple of things. One, earlier, first of all, I wanted just to go back to something you mentioned that's very powerful for people that are watching and listening. One being the impact is also on the mental state, and as well what you said about the loss of vision. That's something I wouldn't have thought about, personally. I mean, this is like a first to hear that correlates to a potential loss of sight. That is. Unbelievable to even hear. And so that opens up the eyes, I think, of everybody that's and the ears of people watching and listening right now, because it is a high risk. And again, the impact of bullying and things that can occur in that age, especially at school. And we see a lot of these things, and we talk about mental health. We have a few shows about that, and these things are all tied together, and eventually they're problematic. Also, you mentioned about the access, doctor, in a way, because there's a limitation of who are the providers that can actually cater to this type of disease. And again, we're talking about 50 states, for example, just in the US. And that is a big problem because even in the US, we have inadequacy of providers in certain parts of the states, let alone the whole nation, right? So even the cities are not equal, in some where you can get to the best of the best. There's also cost factors, insurance factors. All these things are actually to really worry about. So that's one. Thank you for literally bringing that to us, so at least people are aware. Now, the other part is you are the surgeon that takes care of this at early age, but so is there what's that procedure like? How does it work, and what does it do, and what because people have been like, okay, well, if I
Yeah.
I don't want to go surgery, like, but what's the benefit of it, and is there a protocol before that can actually help? Because I've heard this many times before people go on their surgery, they usually want them to drop a certain weight to get them in. Is that a real thing too? So
Yeah.
doctor, enlighten us with that information.
Okay. Well, let me go back to one of your other points, and then I'll address that, which is the insurance issue, which is a huge issue. And if you look at Medicaids across the 50 states, they vary in what they cover in terms of surgery or medications. With children, there are only 13 states where their Medicaid covers medications for obesity in children, which is another advocacy issue that I'm working on because that's crazy. Like, why can you only get certain medications in certain states? Like, that doesn't really make sense. But actually, again, like the surgery side actually was and somewhat is still easier to get insurance approval for because the long-term data are more available, right? So people may not remember, but bariatric surgery started in becoming common back in the 90s. And so it's been around for 30 years. And so we really know a lot about pros and cons of surgery. The technical aspect of surgery has changed a ton. And so the complication rates of surgeries are now 1% or less when they used to be much higher. And unfortunately, sort of like obesity in general, obesity surgery has a really bad PR problem. People think it's like, you even said yourself, it's a last resort, and it doesn't actually have to be a last resort. And in some people, it really shouldn't be a last resort. But that's a whole nother topic. Um, and for kids, again, again, the critics, I was just answering, I did a podcast like a couple of weeks ago and just answering some comments in the comment section. And one of the comments was, there's no reason that a child can't lose enough weight with diet and exercise, and no child should ever need bariatric surgery. And I just responded and said, listen, you're just 100% wrong, because every kid I operated on had already been trying diet and exercise for years. Like, no one comes to surgery like, no one wakes up and is like, you know what? I noticed today that I'm having a weight issue. I'm going to go see the bariatric surgeon. Like, that's not how it works, right? People view it as a last resort, although I said it doesn't necessarily have to be. So I never saw anyone who hadn't tried something else before they got to me. Now, I will say that especially in the early days, most of my patients were the kids of parents who had had bariatric surgery, because the bariatric surgery had changed the parent's life so dramatically for the better. And they usually or often suffered with obesity as children themselves. So when they found me online and found that there was an option for their kid to go through, let's say, high school or college without obesity, they would find me. Like, that's how that was like basically the bulk of my patients in the early days. And then it, obviously grew from there, because people saw the benefit like that. Those kids would go back to their pediatricians, and their pediatricians would be like, wow, look at all these health benefits. Maybe I should send these other kids to Nadler and his program. So the procedure itself for kids, we do something called a sleeve gastrectomy. So it's not the bypass, which is what got all the bad press back in the 90s, because it is a complicated operation that has some real consequences if it goes wrong. But sleeve is much safer, although no surgery is complication-free, and frankly, no medicine is complication-free either. And so there's still a risk. And like every other medical decision, it's always a risk-benefit analysis. And I never downplay the risks of the surgery. In fact, I often overplay them, because I want people to really understand what they're likely going to experience. But, type 2 diabetes can be cured with bariatric surgery. And again, this pseudotumor cerebri or idiopathic intracranial hypertension can be cured, and fatty liver disease can be cured, and sleep apnea can be cured. And all these things can be truly cured with weight loss surgery. Now, again, not in everybody. I often talk about statistics, which bores listeners to tears, but I do it anyway, because the world is a bell curve, meaning like the average result doesn't mean anything to you as an individual, because you could be above average or below average. And what people don't even really understand, I think, unless they have some statistical training, is that only 2/3 of people are even within like a range of the average, one standard deviation in either direction, plus or minus. So maybe 2/3 will respond close to average, but that means 1/3 of people will either be what we call super responders, so they'll do better than average, but then there's 1/3 that are going to do significantly less well than average. And it's why, like, the new Wegovy 7.2 milligram dosing just came out, because there are people who won't respond to the standard dosing and they need another option. So again, like, That goes back to my other comment earlier, which is you should never tell anybody that what worked for you is going to work for them because statistically that's just not true. Um, but again, I think, again, for certain individuals who are struggling with obesity at an early age or have a high genetic burden of obesity, or um, sometimes it's even just families who are just really in tune with what obesity means, and it can be a great option. And again, I like to describe myself as sort of treatment agnostic. I don't really care, especially now that I'm not doing surgery currently because I'm writing my book instead. I don't really, I have no vested interest in what treatment you choose as an individual. My vested interest is that you get healthier in whatever way works for you. And if you need me as a surgeon, I'm around to help. If you can avoid me, please avoid me because that's better for everybody. I used to say that my soapbox was going to my soapbox goal was to put myself out of business. I still say that, although now I realize it's never going to happen. Um, but yeah, I mean, the critics along the way, oh, you're just trying to do more surgeries because you get paid more. I was like, no, I actually don't get paid more if I do more surgeries or not. It's not how my contract works. Actually, I get the same amount no matter how many surgeries I do. So actually I should do fewer because then I get paid more for doing less, but that's not how it works either. Um, so anyway, it's like I talk about this disease because I care about the children who have it, care about the families who are dealing with it, and for no other reason. There's no ulterior motive. There's no I'm not pitching you supplements or peptides or, you know, compounded meds or any of that stuff, which is all over the adult world. But this is in kids. And so, no one's going to do that. No one's going to, there shouldn't be any snake oil salesmen for children. And I'm certainly not one of them.
Well, doctor, I just want to commend you for it for being as open about it as possible. And of course, you do it as you care. And you're right. I mean, you said it. There's not too many of you out there that do this. One, two is it's a needed, and it's just getting worse and worse. So this is something that we need more of you to do this. And of course, education is a big piece of this. People have to understand it. And thank you for actually coming around into these shows and sharing the value and the insights about it. Because for the most part, this probably going to be the first time a lot of people are going to hear the details about it the way you presented it today. At least in my audiences, right? And so it is eye opening to hear all the stuff and all the factors, and you kind of cleared a lot of mystical stuff that we we have in our minds about obesity in general. And it is things. If I know we've passed the hour, but a couple of things now. The procedure itself, I mean, is it a long procedure? I mean, does it take what's the recovery time? Because people sometimes are considering all these things, are like, oh my
Sure.
God, I don't want to go. Yeah.
Yeah. So for kids and adults, so all these procedures are done what's called laparoscopically. So like 5 small incisions. You're out of the hospital in one night, usually, sometimes two. You're back at work or in school in 2 weeks. The procedure itself, at least a sleeve for sure, takes about 45 minutes. It's amazing, actually, how it's all progressed over the last 20 years. But yeah, like on my busiest days, I would do 4 of these operations in the same day. And it can definitely, help a lot of people. But it's not the same old surgery that used to get all the bad PR. But again, I don't want to be like perceived as pitching surgery because I'm not. But I think people just need to like there are a lot of misconceptions, myths about obesity, treatment in general, and bariatric surgery specifically that just need to be busted. There was that old show, Mythbusters. So I kind of,
I love that show.
yeah,
Well, doctor, but it is, thank you, because at the end of the day, you're right. I mean, listen, I've had many discussions with surgeons, and they always say, like, if you don't have to take surgery, don't. But when you have no choice, it can save your life. It can make a big difference in how you opt, you optimize your life and everything. I mean, to your point, it's by the way, I thought it was going to be more complex than what you mentioned. I mean, it's you made it sound like, it's
Well,
not a very,
I mean, for
I mean,
kids,
obviously,
yeah.
yeah.
And what we do is we actually remove about 80% of the stomach um, with using a stapling device. That's actually what a sleeve gastrectomy does. And if people are interested in that, there are a bazillion online videos of it, or in my, there are videos on my website, and it's there's lots of public information. Bypass is still done in about 25% of patients in the adult world, not really very often in kids. And that's the right operation for a different select group of people. So obviously talk to your providers about these sorts of things, but it has developed a lot. I mean, again, it's been around for 30 years, so we've come a long way.
Thank you, Doc. And by the way, you said something also powerful for our audiences, just to reiterate, is the idea that it could reverse some of these, dangerous illnesses that come along, such as diabetes, hypertension, all these things that you mentioned. I mean, I think, if I'm not getting wrong the idea that if you do this and that's the ultimate option, as opposed to just testing it out with medicine, so on and so forth, and getting worse. Because again, there is a side effect to medications, in the
Yeah,
long run, your kidneys, your liver. So there's more to that. So you can bypass all that and maybe avoid all that by
sure.
opting into a surgery if it makes sense. And I'm sure,
Right.
doctor, you
And
guys do all your assessments as well. So on
right.
surveys.
And I mean, there are about 20% of patients who either don't lose enough weight with surgery or who have weight regain after surgery. So it's not perfect. And I do think there are going to be patients out there who, I mean, I know that there are patients out there who require medication after surgery. There are people who get medications first and then surgery. There are people who get medication and then surgery and then medication. It just really depends on you as the individual and what your biology is driving.
Doctor, that is a big point. You mentioned a few times, and it is worth really reiterating again, is that everybody's unique, nobody is duplicated. So your metabolism, my metabolism, me and my kids are not the same. We might have some similar genetics, we might have some imprints and transfers of some, but to your point, and that rule applies like, well, I'm working out, I'm not getting the muscle. Well, there's the metabolism, there's your genetics, there's your age, there's the other thing. I mean, age is also a big variant. I mean, obviously kids, they
Sure.
have maybe a shorter, span. I mean, you're talking about from, I don't know, 5, to maybe 15, right? Is that what like to 18? That would be the considered age for a pediatric.
So it depends, but most children's hospitals go up to 22. And
Oh,
actually,
wow.
I used to take care of even older than that because I think a lot of young adults, especially if they have autism spectrum disorder or some other complicating factor, um, a lot of them are better served at a children's hospital than an adult hospital because their needs are more in line with what teenagers need as opposed to, you know, 40 to 50-year-old adults. So it really depends. But yeah, like in general, pediatrics or adolescence is defined, I think, by the World Health Organization up to age 19. So it really just depends on you know, whose guidelines you follow and what you believe or whatever. But
Well, so Doug, so now the ultimate question. There's only you, and you cannot be in 50 states at all times. How do you tackle that when people, I mean, are you able to see people from different states? I mean, do you
so there
travel? I
are
mean, how does that
actually,
work for you?
yeah, there are pediatric bariatric surgery programs and pediatric obesity weight management programs in, I can't, they're not in all 50 states, but they're probably in 40 or so, let's say. And I do work, I spend a lot of time trying to train the next generation. And we, not just me, but the guys who are all doing it around the same time I was doing it, we all are trying really hard to replace ourselves and train the next folks who are going to take over the lead. Um, and so right now what I do is if people contact me is I try to help them find places that are close to them to help out. And I did for a short period of time have a telemedicine practice where I could see people from lots of different states. But that's a whole nother, yeah, I mean, that's another difficult um, nut to crack because of all the hurdles that exist with insurance companies, et cetera. So even some of the big online weight management practices are getting out of the pediatric weight management business because it's just so tough. So there's a lot of advocacy work that needs to be done at all levels. And that's why I'm out here trying to spread the word so others join in and help fight the fight.
Thank you, Doc. And I just want to add one more thing because you're talking about the insurance space right now, and that's kind of like my word. And you're right, not all the states are equal in terms of what they cover, and not all the insurance companies are equal in what they cover. I know, for example, I've been in New York market, so it's a little bit more, I guess, open to a lot of the stuff compared to a lot of states.
Hmm.
And you get into the southern states, maybe the Midwest, you'll get less and less, in favor of a lot of these things. And so it changes. The Medicaid programs, you said, they vary from state to state. So because of the way they run their funding, that can be a challenge. And you're right. I mean, I do, for example, like I've been in the Medicaid, government programs and Medicare. That's my career path. So we work a lot in those benefit, packages. And I mean, for the most part, it's covered as long as it's, there's a need for it. And I mean, doctors have to present the case that this is the ultimate solution to solve. And from an insurer's perspective, I mean, when we think about it, the risk is mitigated. Like, well, if we can save, we can pay for a procedure now and save in the long run. I mean, it makes sense, right? And so,
Hmm.
because it's only going to get worse if you don't do any job,
Yep.
and eventually you might not even avoid a major surgery later on, cardio and other things, right? So it can be, almost avoided by doing the right thing up front. But you're right, is the dynamics are not as simple as people think. But at least to your point, you're doing the advocacy. Hopefully, we can get this show to a lot of folks out there and get some of the experts and maybe powers that be to make a difference and see the value of it. I mean, a lot of the medical doctors, I think, from health plans nationally can really benefit from a discussion like this and say like, hey, maybe with this is something we can have at least an open mind to,
I spent a
because
lot of time in my last 20 years talking to medical directors and even going to insurance companies, what's it called? Their committee meetings where they were deciding what's covered and what's not, and presenting my data and trying to, and at least in the DC area where my practice was, I was able to make a lot of changes in what the Virginia, Maryland, and DC Medicaids would cover. Even the private insurers around town would cover, even the federal government insurers. I got them to change what they were doing. I started my career in New York, and yeah, in New York, again, um, the Medicaid covers it, Medicare, and the break-even point for adults really, in terms of cost benefit, is about 3 to 5 years after surgery. The insurance companies have already broken even and start to make profit on the patients. And for kids, it's probably closer to 7 years before they break even. But the sort of people also don't really think about the fact that most children on Medicaid, most adults on Medicaid actually never get off public government insurances. Yes, some of them get jobs and can uh, get their health insurance through their jobs. Most of them get jobs, but getting health insurance through your job is another story. And so the vast majority of people on Medicaid actually are on Medicaid almost their entire lives. So it's another piece of the economic puzzle that people don't think about. Because at the end of the day, it's your taxes and my taxes that support the Medicaids. So, and Medicare. So it's a complex economic puzzle as well as medical puzzle.
well, it is, but again, there's certainly a need for more discussions and more input, and I guess your work is making a difference, and hopefully, I think, because again, the numbers are there. Yeah, you do break even at a certain point, otherwise you'll just be bleeding forever because the problem is only going to get worse, and the additional diseases that will come along, will just
Yep.
add up, and you got to rack up all these costs,
Pay now
eventually
or pay
as an issue.
later. You pay now
Exactly.
or pay
So
later. So you make a choice.
it's simple math. I mean, it doesn't take a rocket science for that. But again, to your point, some states may not be up to that level because they look at it different. Their subsidies are different, and yeah. So, but it is that's we just had a show about healthcare cost and insurance. I mean, it's a big deal, and it's never going to go away. And I don't know how we're going to solve that problem. And by the way, it's
No.
not just in the U.S., worldwide. Now, that's a final question for you, Doc. I know you talked about this is a problem, worldwide problem. Do you have any affiliates, any other, places where people can actually, for someone that may be listening to this in a different country, is there a connection and
So
resources for them?
if you're listening, if you have listeners in other countries, the best thing for them to do is actually email me, and I guess you can put my email in the whatever in the details of this thing, or I can put it in the comments or something. I do have contacts in the Middle East mostly, but it's not. Um, I do have contacts in Europe and other places as well, but most of my main contacts are in the Middle East. But I'm happy to try to help folks find providers wherever they are. So
Well, thank you, Doc. And we'll have your website, so they'll have the exact
sure,
access to you,
yeah,
and they can,
perfect.
reach out to you directly. So yeah. Well, listen, Doc. I mean, this conversation is fun and we're exciting because it's a lot of good stuff that we can share with our, world
Yep,
here. So I want to thank you for really taking the
my
time,
pleasure.
and being with us and really enlighten
Yeah.
us here. And so that's it.
My-
Anything you want to leave our audiences with before
Yeah, my
we?
only ask is, that when my book comes out, that you let me come back on and talk about it and keep this conversation going. Um, people
Mi
should check
casa
out.
es su casa. You're welcome anytime, Doc.
People should, people should, check out my website, my YouTube channel, email me, whatever. I'm always available for help.
We'll have that as well. Like I said, all the links will be there for people to actually reach out directly.
Yep.
And so that's it. We are
All
coming
right,
to the
man.
end. Thank you, Doc.
My
Folks,
pleasure.
listen, an honor here. All right, folks, this is the end of the show. I'm Hurricane H. I hope you enjoyed this discussion. Please do check out the description of the show and the links. And we'll be talking soon. New day, new show, new topic, new guest. Bye for now.